So, good afternoon, everyone. Welcome to the session on best practice of advanced healthcare, integration of laboratory insights in healthcare management. This is a session supported by Abbott and by especially the project Univans. We're going to learn a little more later during the session. I have the difficult task to introduce a very, very important topic, which is the evolution of lab medicine and laboratories in the current transformation of healthcare system, and we're going to have a full discussion about how this evolution is taking place and what we can expect in the next years. Together with me, there is Mr. Korshov. Did I pronounce it well? Kosnov, sorry. It's very difficult. Shoturbani, Mr. Matthias Nielen, over there. Professor Michael Haas, over here. And then you have Ms. Patricia Ravalico from Abbott. I'm going to say a couple words just to set the stage, and then we can move into the presentation, and then we're going to have a panel, and we'll open to the audience the debate. From my perspective, what happened over the last 10, 15 years is that we often have the sense that laboratories and lab medicine was sort of considered a commodity within health organization, health system. So something you can take and put wherever you want. It was just a sort of a problem of a production site. Not really being engaged or involved, integrated into clinical activities. Even if we know that every physicians need actually a lab test to be proficient in his or her profession. Anyhow, the question was, because we have cost containment issues, because we have new opportunities given by technology, let's put the laboratory wherever we want in the most, rather say, potentially efficient place, but not necessarily the best place to provide the value the lab can give to the clinical side. Then what happened? In the last years, new tests came here. Precision medicine emerged, then we have omics, and we have a number of new opportunities that actually made the medicine laboratory becoming again more central in the clinical practice than before, and that also require regulating some of the traffic that now we have between specialized exam, quite expensive. The quest for reducing the inappropriate exam that are done on the other side. So something came out in the new scenario as a sort of a new phase in which lab medicine was again central to the agenda, or looks like central to the agenda, even if lab physicians didn't do much actually to support or help this process. So the opportunity are there, but we still don't see full, or rather say, exploitment of these opportunities. Some of the lab physicians should probably go back to the shop floor, working in integrated team with the clinicians, becoming even a steer force for clinicians. I personally have the opportunity to run for a couple of years, more than a couple of years, almost 4 years, executive program for lab leaders. And one of the things they really fail in doing, and they decided now it's time that they start doing, is becoming more like a actors or protagonists of a clinical governance process within their organization, challenging the request for exam done by clinicians or supporting them in introducing innovation. Okay, so that's actually reshape and reconfigure to some extent the role of lab physicians. And finally, what happened is that because of this, now we see an organizational transformation, because if you want to free the time of lab physicians to do their job on the shop floor, if you want to make sure that you still guarantee safety and quality in the production process, but at the same time you reconnect the lab to the clinical floor and you have integrated team, some reorganization are taking place, and we need to make sense of these organizations, and we need especially to diffuse those innovations into the system, make sure that every lab that is doing something very interesting from an organizational viewpoint, from a production process viewpoint, is made available to the others, so we can have what we usually call learning by benchmark, or learning through a comparison. We need to have announced that, and Univance, the project of Univance, came right in place because okay, we have a revolution to some extent because of that new test, because of organizational transformation, because we want value-based healthcare, we want the lab clinicians close to the other clinicians, integrated team. So Univance gave us the opportunity to have an insight on this transformation. And now we're going to see through the speakers what's really going on. We have very expert speakers that really have their hands right on the context of lab medicine. So I'm going to leave immediately the floor to the first of the speakers. Thank you. And I'm asking you to self-regulate for the timing, obviously, so to leave enough time then for the panel discussion and some of the debate. The floor is yours. Thank you.
Today, in many countries, we wait until the person is sick, they seek care, physician sees the patient, forms a hypothesis of a diagnosis, not a diagnosis itself, and then says, let's run some tests. Very reactionary, and the reaction means the patient is already sick. So clinical lab, value of the lab, or practice of laboratory medicine, or field of pathology, are all the same. It is basically subspecialty of the medicine. So pathologist in US or consultant from UK, or maybe called someone else, they're first physician, and then their subspecialty is actually laboratory medicine, but it is not looked truly like that. So we are part of the medicine, not outside of it. We do three things well. So we basically spend 24 hours a day, 7 days a week, save lives. So clinical lab is utilized to manage or optimize morbidity and mortality, one and most importantly. Two, we are a way to manage and measure quality of outcome. And three, if and when appropriately utilized, we not only can actually reduce the downstream savings of a particular patient, but the population at large. And that's a story I'm going to share. And there are 5 reasons that we are positioned to do that. Number 1, lab is the first responder. We're the first to actually scientifically to basically tell the community there's an infectious disease breakout. So what happens in terms of a time and accuracy of the diagnosis determines what we do to that person. So time to diagnosis and diagnostic optimization is the catalyst to the entire continuum of care, which leads to care optimization, leads to therapeutic optimization, and ultimately screening and surveillance. Not all the time we follow this, but if you make a mistake on the first stage, misdiagnosing it, some very bad things could happen to the person. So lab is really the first responder by scientific methodology. Number 2, we're the largest touch points in healthcare. That means we touch more lives in community than any other ancillary services. We touch lives at home, emergency room, outpatient, and inpatient. Each of these touch points are measured in a unique, structured value. How many of you are in the digital space? By show of hand, okay? So lab is probably your gold mine because 70% of the clinical entire data comes from the clinical lab. So each touch point is actually clinically actionable, what to do and what not to do. Obviously, 70% of the clinical decisions come from the clinical lab, and it can verify the physician's hypothesis. It rules a condition in and rules a condition out. 3, it's real time. There is no latency. So the word surveillance is nothing new for clinical lab or for public health. We've been doing it for years in the realm of infectious disease. It's a matter of expanding the surveillance to other chronic conditions so we can basically decide what happens. So if and when we are able to create that database from around patient-centric longitudinal view, we are able to real-time measure change. Real-time measure change, and that measuring change is what we refer to as precision medicine. How the person changed compared to themselves, even within the normal range, this is actionable. Number 4, lab is the first to know. That means, how many of you are from a payer space? Insurance side? This is where the story gets really, really better now. Because we are sitting on massive amount of data in a longitudinal fashion, and we're able to measure change, now we can begin to actually develop a risk stratification of conditions that we're targeting that have disease prevalences. And by risk stratifying it, now we know exactly who has care gaps and be able to actually close gaps in cares. We're able to identify patient high risk early before the person is actually hospitalized or gone to emergency room. And last but not least, lab has the actually ability to facilitate an intervention at a zip code or geocode that person needs intervention before actually that person has shown any symptoms. So lab can do a lot today, but lab can't do everything and needs key partnership. We're actually utilizing this very concept to predict who's going to be at risk of opioid overdose so we can actually intervene. And the whole idea is how do we basically take longitudinal view of an actionability of that data, map it to a zip code, partner with the social determinants, be able to design the clinical care processes that we can actually intervene patients such as opioid to see who's going to be overdosed and intervene before that happens. It's really tragic that in the US we're losing more lives than car accidents. It's an unacceptable social behavior. And this is what we're utilizing to harness the power of that data. We're sitting on it, but we haven't leveraged it to the extent that we should. I am of the opinion that my own quote, that if we, lab, wait long enough to label a patient, we have failed that person. The meaning of patient means suffering. So if we want to be in the wellness business, we ought to change the terminology. And the whole idea of moving only the sick people into a lower risk threshold, which is a good thing to do, but it doesn't accomplish the objectives of the population. To manage the entire population objective, we have to remove all of them into the lower risk. And lab becomes obviously a platform of that because we're the first to know who's actually showing some changes. And obviously the last piece. You might be surprised that for every dollar we spend in healthcare or every euro we spend in healthcare, we roughly spend about 3 pennies of each dollar in entire diagnostics. We call ourselves cheap bargain or cheap date. I'd rather be a cheap date as long as we are a date. But the 3 pennies of every dollar that is basically gives us actionability of that information that is not a hypothesis based. It can help us manage the sick care who needs to basically lower it in critical care to a lower department that doesn't need to be in an ICU, or who needs to be discharged from the hospital. But more importantly, lab becomes a vehicle, a catalyst that helps us in strategy of intervention, prevention, cost avoidance, and risk adjustment. We're basically an unsung heroes that haven't been able to have a seat at a table in the wellness to be able to maximize the value that we bring to the table. So, in summary, we're the first responder. We know first because we are the catalyst of the continuum of care. If we don't make the right diagnosis, something harmful is going to come to the patient. We're the largest touch point of data that has actionability above and beyond just hypothesis. It's real time. There is zero latency in lab data. And obviously lab is the first to know if something is about to happen so we can be prepared for it. And obviously it is really a cheap bargain, but we need to leverage that. In conclusion, so we manage morbidity and mortality. We are able to measure and help influence the outcome. And last, we're probably best bargain for the dollars that we can bring to the table, reduce cost per patient or the overall population health. That's the value of the clinical lab.
Thank you very much. You really set the stage for the rest of the discussion. Just let me make a quick comment because this is really interesting. When it comes to the fact that there's a discussion going on in many systems about the fact that 20–30% of the lab tests are inappropriate, they should not be used. But then we don't remind that one test can save a life. And if you want to move into a population management approach, then you have to increase the number of people that will be tested for risk factor and continuously monitor and assisted by the GPs or by whoever actually is in charge of guaranteeing that patient is under control, educated. So we're moving from a medicine of reaction to a medicine of initiative, and lab has a central role in this, even more than before. So I think lab physicians need to be very serious in being on the right side when it comes to provide the right utilization of expensive tests, and that's where you have to interact with clinicians to make sure that you do the right test for the right person. But on the other side, they have to advocate for a larger use of lab basic tests for the population in order to enhance the possibility that population management approaches, chronic care models, whatever you want to call them, really become effective. Sometimes I feel it's really strange system that try to save money on lab tests when it's 3% of the pennies out of $1, and it doesn't really make any sense. I mean, if you look at it from a health policy perspective, it's just rationing rather than improving the system. Professor Michael Haas, please, the floor is yours. Thank you. Give us some insights.
Can you hear me? Yeah, now I'm on, I think. Yeah, thank you for a nice introduction. Thank you for the organizers for the invitation to present on a kidney healthcare program, including, well, it looks different, including improved diagnostic pathway and treatment for hospitalized patients with acute kidney injury. And the reason why we chose acute kidney injury is that it is a very endemic condition during hospital stay. Every 10% of patients treated in the hospital are affected by acute kidney injury. And it is also a very, very prognostic condition, which means it is tightly associated with mortality as an independent risk factor, accounting up to 20–25% mortality. And also, a patient developing acute kidney injury often develops complications, such as renal acidosis, hyperkalemia, fluid accumulation in the body. So it is a very challenging syndrome. But also it has consequences on the long term for affected patients. So all taken together, it is a condition you don't want to have, or you want to have recognized early and treated effectively. And this is why we kind of formed initially a relatively regional Potsdam initiative for AKI care, involving laboratory medicine doctors and hospital nephrologists and outpatient nephrologists. So a very interdisciplinary team, which I'm very happy that we have this. And our intention is to improve the suboptimal standards of care for patients with AKI, including enabling timely diagnosis and treatment. And just as a background information, to keep it simple, you only need to keep in mind that acute kidney injury is already diagnosed as soon as a creatinine increase occurs above 50% from its baseline value. And this underlines what my predecessor already pronounced, that we need to have more options on longitudinal data, and that pathology values need to be connected between the ambulatory or outpatient and hospital settings to early recognize such changes. Well, why we formed this initiative, we discovered, unfortunately, that things are at least true or even worse, which we could read in the literature in our own patients then, with an incidence of 4 to 9% measured on 2 different hospitals. And it was associated, AKI was associated with doubled length of stay in the hospital, increasing from 7 or 8 to 15 days. I mean, that makes a big difference also in cost, but also in the risk for the patients, being longer in the hospital environment to acquire hospital complications such as infections, thrombosis, whatever. So patients carried a truly poor prognosis with a hospital mortality rate of 15 to 23%. Is it myself? No. What we found out was that 75% of patients developing AKI were previously undetected before we started an electronic alert system. So only 25% were correctly diagnosed, and the diagnosis was correctly documented and responded on. And obviously, unrecognized AKI or poor recognition led to poor management, with more than 80% of patients with nephrotoxic medication not paused, and also antihypertensive medication in the setting of hypotension and AKI not being paused. So this was the basic condition we were starting our initiative. And patients with AKI developed renal complications in 49% of patients, hyperkalemia, renal acidosis, lung edema. So we hypothesized that if we were able to detect this creatinine change, so which is creatinine, assumed creatinine is a blood test enabling you to measure kidney function over time. If you serially measure creatinine in your lab, hypothesized that early detection and combined with early kidney treatment would improve outcomes. And we implemented an AKI alert system together with the hospital medicine doctor and on a hospital-wide basis. So every ward was basically supplied with these, or included in the AKI alert system. If that was surgery departments or internal medicine or whatever you think, every patient was then monitored in terms of creatinine changes. And because in the pilot or run-in phase, we learned that only detection and flagging AKI is not enough, we actively combined it with a kidney response team, this AKI signal. And the execution involved the automated summary report of the AKI alert system for the clinicians who were also informed about AKI occurring, but the clinicians were also made aware that the kidney response team will show up at their wards and supporting them in managing patients affected. And thereafter, including this actually, patients were also informed about their AKI, about the reasons and what they can do to themselves later on to prevent reoccurring AKI or prevent developing chronic kidney disease. So there are numerous of advice which can be given to patients, and this is what we have done. So what were the results? We were able, I mean, this is pilot data, but still statistically significant already, that we could reduce the proportion of patients with unknown cause of AKI from 25 to 5%. I think this is the first step to change, to find the reason for this condition. And AKI documentation improved, and AKI coding improved by factor 3, which was massive, and the AKI complications were reduced from 40 to 15%, so a relative reduction greater than 50%. And this translated, obviously, also into patient wellness, to be aware as a patient that I will be informed about an acute kidney injury as soon as it occurs, to be aware as a patient that my hospital is screening for kidney problems which are often initially asymptomatic, and I wouldn't realize it as a patient if I had not this technical and laboratory medicine support. And so actually, while speaking with the patients, it became quite quickly clear that they felt safer within such an environment. But the safety issue was also quantifiable, as I pointed out, including pausing of nephrotoxic and antihypertensive medication. So clinician confidence already increased. The chief nephrologist of the hospital stated that the team believed that in-hospital kidney emergencies were reduced by this procedure, this program. This is where we are now on a scientific stage to measure this. But nonetheless, first we have got an impression and then a hypothesis, and then we can check it. And improved satisfaction of other colleagues. They were very happy in other disciplines that nephrology and laboratory medicine supported their care. Documentation, reimbursement increased by factor 3. Complications were reduced, but this is where the program did not stop. It did not stop at the hospital level. We were able to move it forward into the outpatient kidney care system. The idea behind it was the knowledge which was previously published several times, but I show you this impressive example where on the long term, after AKI, if patients were followed by outpatient kidney doctors, their mortality decreased actually because cardiovascular mortality was reduced through a good blood pressure management, through lipids measurements, and through preservation of kidney function. So in a first step, we found that in a 12-month period in the hospital, I mean, the origin was obviously still in the hospital, 40,000 patients were treated, 2,000 had AKI alerts. After cleanup for these alerts, we were taking away false alerts. 1,230 true alerts were left over. And the e-alert was carried out with the team, with the responding team in the hospital, but not yet in the outpatients. But we found that of the 1,230 patients, only 76 patients were previously in nephrology care, and after AKI alert, only 24 patients were in kidney care, in outpatient kidney care. And in the same period of time, 239 patients were admitted to our outpatient kidney care center but they were sent by their general practitioner due to chronic kidney disease. And comparing these, 1 minute, I will make it. Comparing these groups of patients, you can see on first view that they are similarly sick whether they come because of chronic kidney disease or because of an AKI alert, in terms of their cardiovascular status. And you can see on the left-hand side that their kidney function, when sent by the general practitioner for chronic kidney disease, was higher, even higher than kidney function when presenting after an AKI alert. And this is reflected by renal complications, where the pathologist, the laboratory medicine doctor, is involved very heavily, measuring the acid-base status, measuring parathyroid hormone, and measuring reticulocytes in the blood. So what we improved together with the pathology laboratory medicine was the discharge letters as well. Patients with AKI get now documentation of AKI stage, cause, interventions, and recommendations to have a cross-sectoral information exchange. So finally, I thank the team, for the inspirational team, for supporting and for making this possible. You need a pathologist, a laboratory medicine doctor, you need nephrology hospital doctors and outpatient nephrologists. And I also say thank you for your attention on a program where the patient care is in the center of the cooperation of pathology medicine and nephrology. Thank you very much.
Thank you very much for showing us a case in which integrated coordination among different disciplines and professionals and the utilization of lab as a screening and can really make a difference for the patients. And that was really a patient-centered exercise that we like a lot and what we would like to see in the future. Sometimes actually you wonder why you didn't do it before. When you see, it's so simple. When it looks like, I mean, even if the research was really well conducted. And
do you want me to respond?
No, because later, after when we're gonna have a panel, you can say what the why is still interesting. So, floor is yours now, please. Yeah, you can move to the podium. So, Matthias and Nilen.
Okay, good afternoon. I'll give the feedback to the both nice presentations from a health payer perspective. What I would like to say first is that we've heard it a lot the last 2 days, but it's also true for lab medicine, is that we need to move from the fee-for-service system that in Europe we know right now to a system that values more the value-based system of healthcare. Because in a fee-for-service system right now, the lab doesn't really help the patient. The lab is used for the wrong things, and I think the first presentation said it very nicely, what the lab should be used for, and that as a payer we can also agree with that, is that the lab has to become more integrated in the care pathways. That is what's lacking today, and which costs a lot to the system. I think you said it, 30% is wasted. Also in my country that's true, 30% is wasted. The thing is not, should we do more testing? No, the thing is, how can we do the testing better? Like, how do we connect the dots that are not connected today? We keep testing, but the question we should ask, and I think the presentations come to that, is we shouldn't do testing for the testing, but we need to test with in mind. We want a certain outcome, we want a certain result, we want to know something about the patient. Which test do we need to do for that? A critical comment is that as payers, we need to keep an overview on the whole system. And you have the balance from what we see now, which is under-screening, and you can go all the way to over-screening. So it's a balance that I think with the new lab, with the lab 2.0, how it was said in the first presentation, it's a balance we have to search for. I think right now we're doing, at least in my country, but I think in most of Europe, we're doing an under-screening. We don't screen enough. But we don't want to go to a system where there's over-screening, and that we don't want society to be all medicalized. People need to be worry-free sometimes, not always worried that something will be wrong with them. So over-testing is something we want to avoid as payers. So for the first presentation, the things I would like to remember from a payer perspective is that it's very important to integrate the lab in co-decision making. That the lab works needs to be integrated in the path as a goal-oriented lab. It should be cost efficient. Well, of course, I speak for the payers, so that's always a topic for us. We need to find what's cost effective. We want, of course, with all that, the main focus is better outcome for the patient. That should be everyone's focus here today. I think the whole weekend is about that, the 3 days. And one thing that we would like to emphasize is that there should be some risk profiling. To start screening the whole population, it's interesting, but I think we should start with some risk profiling and then see where we can move on from there. So that was the comments on the first presentation, then more into detail about the post-time presentation. Actually, I want to go further on the last question that was asked. When we see something that works so good, it's very surprising that it's not widespread in the whole of Germany or the whole of Europe. If it's something so evident, so cost-effective, we can see those things. And I think the healthcare payers and the system in general is kind of too slow there. The way we've grown from the past, also from a payer perspective, we need to change some things, and we're still looking for what that can be. Another thing that for payers is always important is prevention. So I think the slides that were shown are, yeah, I mean, if you can see the results already in just detecting AKI sooner, I wonder what can be the advantage of even preventing AKI from happening. That's even the next step. So we're saying we're going good now, and that's where lab can help. Let's see how we can go to even preventing from AKI happening so many times in a hospital. Maybe that's the future, but that's the next step we should be taking. Also, that was mentioned in both presentations is something that as payers is the importance of sharing data on a national level. I think the last example of the patients being followed also as outpatient data it's very interesting to see. So you should not only focus on the data and the hospital, but really overall, and that's where you need the national data for. But a question that I want to pose, and I don't have the answer right now for that, but it's who will be in charge of those data? Because it's, in Europe at least, very delicate to work with the data. You have the privacy protection, the laws that are changing. So who will be in charge? Will it be healthcare payers? Will it be the systems? Will it be physicians? It's a question to ask. I think those were my main points of focus. Thank you.
Thank you very much. Thank you very much, Patricia. It's very interesting because we have a session with all the different souls. We have the clinical side and all the production side. We have a professor from the University of Medicine or from the medical school. We have the payers, and now we have the industry. And thank you for providing us the opportunity for this discussion. I'm going to be provocative right after your intervention. I have a couple of questions for all of you about what we're going to do. Yeah, Tricia, go ahead.
Wonderful. Let me just make sure I have my... Okay, here we go. Okay, hello. My name is Tricia. I work for Abbott. I run the Scientific Leadership Group, which is an organization that's focused on both education and evidence, both within and outside the laboratory. A key area of passion for us is achieving measurably better healthcare performance. And how are you measuring it? How are you doing it? How are you leveraging technology, including the clinical lab, to get there? And the only thing that I'll say before I get started on the Innovant presentation is that a lot of the discussion here so far has really been focused on over-testing or under-testing. And the piece that I'd challenge us to think about is when we think of the clinical lab, it's not just about that test result, but how that test result is integrated in the pathway of care, which really leads to that transformation. So in the case of Michael's example, creatinine was being run in patients suspected with AKI, right? And we know that if creatinine is outside of the normal range, it's already suggesting the damage is done. But as he also presented, if you see a delta change of that creatinine and it's substantial, doubling, right, greater than 50%, then all of a sudden you start to recognize that this patient is having a problem. It's trending in a direction, and you didn't have to wait for the creatinine to be out of range. And so again, the application of the data is just as important of how you use that data. But I'm here to talk about the Univants of Healthcare Excellence program. which hopefully is a name you guys know because we've had that flyer upstairs on the second floor. But it really is a foundational program that I think speaks to a lot of the principles here at EHMA as it relates to sustainability of healthcare, but also the transformation of healthcare through integrated care teams. And so on this left-hand visual, what you see is all the different aspects and potential sources or touches of care associated with the patient, or, as Kaiser says, the pre-patient consumer, right? The ones that we're trying to prevent from being a patient, coming together in this transformational new way, okay? And that roadmap is sort of the roadmap that we all seek, which is what is the direction to get to measurably better healthcare performance. Now, the name Univance, which is the award name, is based on the founding principles of two key topics. The first, teamwork, right? The uni in Univance is about unifying across the care continuum. Okay, so in Michael's example, the creatinine, which also was generated by laboratory medicine, involved IT. Very simple use of an algorithm, but in a very complex way through education that was required to change the pathway of care, leading to all the outcomes that you saw. So the Vant in Univant is about being avant-garde, right? It's about doing things differently. And that can be as elegant or as simple as a clinical decision support rule for any one disease state, or it could be as transformational as an entire care pathway for patients that present with acute coronary syndromes. So it looks very different. And I think that's really the beauty of the award, is it starts to elevate best practices across different disease states by care teams across different interest levels in a way that inspires more people to work together and celebrates those that have for the achievements that they've achieved. In terms of outcomes, a key question is, how is success measured? And so to be a recipient of the award, all care programs essentially have a measurable outcome in each of these four stakeholders, right? So in terms of the patient, how is that patient experience improved, or their patient diagnosis, or their safety enhanced? In terms of risk mitigation on behalf of the payer, how are you saving costs? How are you, even if you have to pay some costs to save downstream costs, how are you improving that pathway of care? Clinicians, how do you enhance their satisfaction, enhance their confidence? How do you improve their experience? And this can come in completely different forms. And then similarly, to the health system, in what way is utilization management of resources optimized? In what way has the reputation been enhanced because it's now a center of excellence? In what way, I don't know, there's lots of different opportunities for the KPIs associated with the hospital system as well. So anytime you have an award program, it's important to have an unbiased approach. Abbott sells diagnostic equipment. A piece of this is, how do you use laboratory diagnostics in the measurably better healthcare performance pathway? And so we've removed ourselves from the judging panel, but we've partnered with leading professionals, leading organizations that share in the common mission of improving and transforming healthcare, right? And doing it together. And so just as we're asking care teams to work across the care continuum and unite for a common purpose to show measurable value, we've also done the same. And so that's why we've partnered with EHMA. You can see that there's numerous groups of partners that represent IT, C-suite, healthcare quality, healthcare economics, laboratory medicine, okay? And the role of the partners is multifactorial. One, they share in the call to action, which is to inspire care teams to achieve measurably better healthcare performance, to work together, leveraging unity and avant-garde principles to actually get there. Two, they celebrate the success with us. So when there is a care project that each of us have all decided deserves recognition, then they celebrate and share that best practice. What I heard here at this conference is that there are a ton of best practices that have already probably been candidates for this award. It's just a matter of applying. And the more we amplify and celebrate and show that best practice, and I think that addresses the question, which is, if it's so simple, how come it's not done, right? It's so simple if the right stakeholders are at the table. It's so simple if everyone is not so busy doing everything else that you can see the trends. Somebody that has done that effort and has discovered that pathway and can teach on it, can help other people do the same. And that's really the principle behind amplification of these awards, to celebrate it, to also inspire locally more care projects within that health system to continually achieve measurably better healthcare performance, but also other care projects around the world to also share that opportunity. Okay, so we launched the award program. It was August of last year, and in less than a year, we achieved over 97 countries. It's over 100 now. And you can see that when you looked at like the top 10 most engaged countries, you're not seeing any of the Nordic countries. So this is important to really invite you to get more information on the award program and to share your measurably better healthcare performance best practices. Because I know from already the last couple days of discussion here, there are best practices to be shared. The other thing I wanted to say is that we had over 100 applications this past year in our first year. And the announcement of those applications in terms of which 3 care teams won the physical, or winning the grand prize, if you will, and then which one got recognized for distinction and or achievement, that announcement will come in August. So stay tuned. That's kind of my, I can't really announce it here, but I can tell you that the photo shoots and all the activity associated with helping educate on those stories and preparing the content associated with those stories are now underway. What I will say is that when you looked at all the applications, so this is not just the top 3 winning teams, you could start to see what were some of the KPIs or key performance indicators that were across the different disease projects, and everything from increasing clinical confidence to improving patient safety. And so there were metrics across all the stakeholders. Some of the care projects involved only 4 KPIs, so just 1 KPI per stakeholder, and some were as thorough and as vibrant as 33. And so with that, I'm going to close. This is the website for the Unimonte Healthcare Excellence Program. I will say this, that when we also in August are announcing the winners, the portal for the 2020 awards will open. And so there's about, I think it's like a 6 or 9 month window to really start to apply. And I encourage all of you to go to the website, even today, to look through more specifics associated with the minimum criteria. Think about all the great things that are happening in your institutions. Think about all the great ways that you could be measuring the impact across the care projects and leveraging the data from the clinical lab, which isn't always going to be related to the number of tests. And I don't know, if I have 1 more minute, I'll give an example. Okay, yay. Okay. Good. Okay, so another might example would be, I mentioned acute coronary syndromes. As a woman, this one's important to the women in the room. The biomarker that for the diagnosis of acute coronary syndrome or a heart attack is troponin. And, troponin's always been used. In fact, it's been since 1998 that troponin was the recommended biomarker to use. And delta troponin is important to look at when you're looking for that rise or fall to separate acute versus chronic. All the contemporary troponin tests, which in lab medicine talk, is about precision, was essentially insensitive, inaccurate. And so you couldn't actually use low cutoffs. The problem of not using low cutoffs is that you basically were missing people that were potentially at risk. And so there was this ask to actually create better assays to diagnostic companies that actually measure precision at a really low level. Once we did that, we realized that female and male cutoffs were substantially different, and that women have half the value of men for circulating amounts of cardiac troponin. And in fact, prior to that, we didn't even know healthy people had troponin. We thought in order for you to even have it detected, you were having irreversible heart cell death. So we learned a lot. And one of the things that was really fascinating is we learned that women who were now having if we use the same cutoff for men and women had to have twice the heart cell death to be diagnosed with a heart attack. And if you looked at the statistics associated with those that went under cath or those that were operated on, women had twice the mortality, right? And that's likely because we were more sick. So troponin is still being tested. It's not changing. We didn't change how often troponin was being tested. But through lab medicine consultation, sex-specific cutoffs are now implemented in clinical care. And that is changing the number of women that are being diagnosed. It's lowering the number of men that might be going through invasive therapy, and it's actually saving outcomes overall. So that's an example of a care project where the use or implementation of sex-specific cutoffs did require physician education, did enable clinical pathway changes, did show measurably better impact, with not any change to the testing that was done. Okay,
very much, Tricia. I have a question now for the panel of presenter, but also, meanwhile, I'm going to ask the audience if you can prepare any question for them. Okay, so right after my question, you can obviously ask them whatever you think actually is worth. The question is the following one. So, integrated care, multidisciplinary team is where we want to go. Okay, this actually is generating value for the patients, for the professional, for the organization, safety, quality. Okay. So the question is how we can support the quest of lab physicians to regain their central role inside the organization, to get the seat where they want to sit. And I was wondering, maybe one day we're going to have a test of this when the medical divisions of a large hospital will be run by a lab physician. Like it's happening in orthopedics with the geriatrics running the orthopedics. So because we learned that actually geriatrics are better organized than the orthopedics when it comes to enhanced orthopedics. So I'm just wondering if that was just a provocation, but what can we do in order to support them? We need to educate them, we need to provide them. Univance obviously is a project in that directions, but what else? Or how we can exploit the Univance even better?
I'm a huge believer that if you don't have a seat at the table, you will be on the menu. And your laboratory will be sold, and that's a big indication in our country right now. But to have a seat at the table for sake of a seat at the table, that's crazy. To have a seat at the table to actually design the delivery models of the future, bringing some very logical aspect, not just basically from a utilization perspective, but how do you manage the outcome? How do you manage the risk portfolio? And evidence that shows that, we have to prepare that. And frankly, clinical lab has played a very nice role in the analytical stage. We're reaching Six Sigma performance in analytical stage. Unfortunately, on pre-analytical and post-analytical, we're not doing too well. Overutilization is a big issue. Misutilization is a big issue. Underutilization is a significant issue as we're moving towards value-based healthcare. I think that we need to incorporate public health and other parts of economics that gives us a three-dimensional conversation, that we can actually walk in with tangible delivery model that truly matters. The idea of waiting for the patient to get sick is just nonsense. The idea is how do we prevent and improve outcome and reduce call is not a new technology, it's actually here, and it does require new leadership. I will make this comment also. You said, how do you get a pathologist to be maybe chief staff? That actually exists. But our training no longer has, what do you call it, a year of clinical practice, which is the first year. They go right into pathology. I think we ought to maybe go back and look at the residency program that the pathologist does have to have another year of internal medicine before they go into. We're just too subspecialized. And I do think that we need to break those barriers down to have a seat at the table, because we do have something to offer. And
you want to say? Yeah, I love the question because classically the clinical lab has been in the basement, and one would argue that asking for that seat at the table is outside the comfort zone of most clinical laboratory leaders. And I really liked one of the quotes, I'll probably mess it up, that I heard yesterday here at this conference about how there are a lot of leading experts, but not a lot of expert leaders. So I do believe there's core competencies that can be gained in the field of laboratory medicine about leadership for that seat at the table. The other thing I think is that it's difficult to earn that seat at the table when lab medicine, they're known for the answers. You heard Khosrow, we're the first to know, first responder. It is wired for them to have the answer. And I think that part of what that seat is not always about having the answer, but having the conversation related to the direction associated with what are some of the What are some of the care gaps that you're trying to solve, and what are some of the integration opportunities that can happen? A lot of the best practices that we've seen from Univance didn't actually start from the clinical lab. It started from physicians that went to the clinical lab and said, help me solve this problem. And that's one thing that I think they're excellent at doing. So I do think that there's lots of different ways to maximize, one, get them to the table, and then maximize that conversation and that productivity to get there.
Yeah, being asked what roles lab medicine could take over, or how could be even more present, is three issues came through my mind when you were asking. First one, obviously, laboratory medicine could be involve itself much more, and which it already does, into alert systems. Not only AKI alert, but it could be electrolyte alerts with the automated offer in the scenario of hyponatremia, as an example, to then automatically print a label to the ward for a urine dipstick for sodium and osmolality, just as a service, just as a closed loop service to enable and support the surgeon's work on the ward, to take over a little bit of responsibility, to allow, for example, surgeons to more concentrate on their work in the operating theater. Second, pathology, laboratory medicine could be one, or maybe even should be one of the driving forces for combining hospital and outpatients data pools for longitudinal evaluation. I think this is second one. And third one, as Trisha was presenting, it was just clear to me on the spot that laboratory medicine, reaching out into the hospital, offering education, showing fascinating historical developments, and underlining their expertise and liking to listen, obviously, to this, is quite easy, I think. And during the nearly 20 years of clinical work within a hospital before I switched into the outpatients, I never met an unfriendly or an incapable laboratory medicine doctor. It's just time probably to show up. That's it.
You want to add something?
No, this topic.
No. Okay. Is there any question from the audience you want to ask to the panelists? There's one there and one up there with Osman. Another one up there.
Hello, I'm Mihai from Romania. I'm an epidemiologist, so I kind of work with the lab a lot. And what I want to ask you is if you see the need of specialization for clinical lab, because, and let me make a preamble for the question, in Romania, lab clinicians become more and more important. Many of them are in advisory boards of hospitals, many of them, because the microbiologists are working a lot on antimicrobial resistance. You know, in Romania we have a big problem with that. And clinicians, so we have like some separate activity, clinical lab, which is one of the best resource to make money for public hospitals. So both of them got power in the last period of time. And now they're talking about over-specialization, so just do residency on microbiology and another residency on clinical lab, because they say this, they're too different. So one lab clinician that works on microbiology cannot go back to lab clinician and doing automatic tests and stuff like that. And if you see this kind of evolution in your experience. Thank you.
So if you follow the money, as you just talked about, the two conditions that affects even in the United States, admission and readmission, and sepsis being one of them or a few others, Clinical lab has a lot to say about those things, antimicrobial stewardship and what have you. The only problem is that when we're looking at the money, we're looking at our budgetary money and not the area we actually have an impact. 1 day of elimination of a length of stay is a huge impact, yet we're focusing on cost of the purchase of an auger, if you will, or running a test. We need to change the unit of measure, what we're focusing on, versus the unit of measure that we really need to be responsible, as Tricia talked about in terms of a KPI. We need to change the unit of measure that we are responsible above and beyond the size of the test and cost per unit of the test. That basically is going to be enforced if we get out of the basement of the health systems or 4 walls of the lab, because it's going to force to speak different language. So our 3 pennies of the management does manage 98, 97 cents on the dollar every single day. We just need to show our relevancy. And unfortunately, we just haven't done it.
You want to add something? Or
Actually, not yet.
no, yeah. Okay, can we take the other 2 questions, then we're going to complete a round of discussion. Usman, you want to say something over there? And then there's another one up there.
Yes, afternoon, everyone. Usman Khan from the European Patients Forum, as is now. I really enjoyed the presentation, and I have to say, having a payer perspective, I think that's, you don't really see that so often on panels like this, and I think it really made a difference, so thank you for that contribution. Mine is a sort of, let's play with the analogy a bit. It probably won't work, but I'll go with it anyway. That it feels like there was a table and people were coming around for dinner, and the people who were allowed to come around for dinner were the clinicians and maybe just about the healthcare managers. And now, for me, diagnostics were in the kitchen, and they might have been doing some preparatory work, if that doesn't sound too rude. It's very important, but it was out of sight. You've now been allowed to come and actually join that table for that meal, and I think it's incredibly important, and people are being able to see the enormous value that can come from efficient and effective diagnostics. The patients didn't even get invited to the meal. They were the ones being talked about by everyone else who was sitting around having the meal. How do the patients get involved now, especially around the discussions you're having on diagnostics?
Thank you. Can we take the other questions before, so we jump to the round table up there?
Thank you. It's Moritz from the company Well IT. And my question goes exactly in the same direction as Usman just pointed out. So where is the patient's perspective in all that? And shouldn't be the patient an agent of that change? Question to the audience.
I'd love to take that.
Any other last question? So otherwise, I will conclude with answering this question, but also going to ask you if you can tell us a little bit more about how do we pay for lab tests when it comes to an introduction innovation? How do we avoid the slowdown that sometimes we have in the introduction innovation because we're still waiting to decide whether this is worth or not worth, and all the inequalities that actually this generates into the system? Who's want to start answering the question on patient?
Traditionally, we've waited until the person has gotten sick, and then physician forms a hypothesis and runs batteries of tests. Quite reactionary. I'm of the opinion that we got to change the equation, how we look at society at large when it comes to healthcare. And the statement of the patient engagement, or actually I would say consumer engagement, is the next blockbuster of the century. Got to be predominant how we design the business model. In my case, we actually built a business model that basically said patient owns their data and it's about portability. We have the largest touch point than any other, meaning that we touch patients outside of the hospital system way before the hospitals actually have touched it. It's a matter of designing a system that allows that portability and connecting and engaging a reality. Patient portal or some form or fashion that we are able to at least get them engaged knowing what the data means to them, putting them on the driver's seat, and so that we are creating a rich conversation between them and their clinician, and the patient is actually a member of that team. We're doing with them as opposed to them. And in fact, it was a topic around the noon too, if we're not basically put the patient in the centerpiece, actually consumer, not even patient, I think we have failed it. We're going to continue being reactionary. And I think lab's biggest touch point actually makes this business model a reality. So we will know if the patient entered an emergency room. We probably have touched that patient before. We can actually alert that physician what to do and what not to do probably.
Yeah, you want?
No, you go first.
Gosh, there's so many ways to get patients engaged. The first thing I'll say is that patients are already demanding to be engaged. I mean, they're managing their health. They're smarter than ever. They in some cases, know more when they're coming in of their symptoms and have already researched it because it's personal to them. So I think, unlike in some cases you have to pull someone to come to that table, I think patients are going to demand that seat at the table, and they certainly play an active role in managing their health. In terms of patient engagement, I think it was 10% of the care studies had patients as part of the care team. So I do think it's starting, and I do believe that's in part because of, one, the role they already play, and in many cases I think they are in charge, and there are certain care projects that tailor or cater to patients. So that's what I'll say for that.
I could answer your question exemplary. In our kidney care program, patients are involved in terms of being explained about the acute kidney injury, and also they are given kidney care cards where actually AKI is noted and the creatinine value is noted, is taken down, and also the cause of AKI, and also a list of self-education, self-measures, how to prevent AKI reoccur in the setting of, let's say, diarrhea and diuretics also. So it's kind of sick day rules in a bit modified way. This is what we do, and this is what the effect we are obviously still measuring. But I think this is one of the ideas to involve patients in their care. And I'm aware of an app programmed in UK, an AKI patient app, and I think this is next, or already there. It is already present.
Yeah, I would like to add something about the patient, because something that from a payer perspective, of course, is very important. And there is for me, there's some difficulty in that, because we all talk, everyone nowadays talks about patient-centered care and that patients should be in control. But my question is because you have different type of patients. You have the well-educated, literate patients. But if I talk about Belgium, according to OECD statistics, 20% of the people, which is a lot, doesn't score very high on reading and writing. So if you're going to give them information about diagnostics, which I think you should, but the question is how you're going to translate it to the patient. Because right now, online, you can find a lot of interesting data about quality of care. But if I read it and I have to compare, if I have a diagnosis and I have to compare 5 different types of statistics, I get lost. So I think it's very important to get the patient on board. But I think it's very important that we think first how we're going to educate the patient as well. So he really can, so he's not just a subject there, like, okay, they tell me all this information, I'll have to go along, but that he can really start helping the decision making. And for me, I think that's lacking at the moment, and it's one of the things that you don't only have to get the lab more active in the whole decision process, but also the patient. I think small steps are being taken, but it's something everyone is a bit scared of doing, I think.
Okay, any last thought? Otherwise, I will conclude here the session. We are just in time. I think we outline very well a major transformation, because having the integrated care with the lab physicians is giving finally, I think, a real practical or real effective ways of moving forward in the movement that we had on introducing clinical pathways, guidelines. Now finally we see the things happen not just because we're writing documents, but because we're making things happen on a different way. So Thank you very much for the presentations. Thank to the audience for being with us, and enjoy the rest of the EHMA conference. And we'll see you tonight for those of you who will come at the gala dinner. Thank you. Thank you.